All right. I think it's about time. So good evening, everybody, and welcome to the third edition of the IIMA Healthcare Alumni Special Interest Group webinar series. The alumni special interest groups at IIMA are platforms that bring together alumni, faculty, and students and leverage the collective intellectual resources engaged in specific areas such as healthcare, education, technology, analytics, public policy, entrepreneurial ecosystem, etc., to bear on the most challenging issues of our times. Now, faculty and alumni are already making stellar contributions, but the ASIG platform allows them to collaborate with each other on a much more intimate level and to engage with industry and practitioners in a much more multifaceted manner. Now, to facilitate this interaction, we have created 14 such ASIGs, and more will follow in due course. The IIMA Healthcare webinar series brings the thoughts, views, and expertise of renowned experts to the IIMA community. These are structured as panel discussions or as dialogue between eminent speakers. In the previous sessions, we have dealt with um, the immense challenges the healthcare sector is facing and how government and industry collaborated at an unprecedented scale to take on this challenge. We've also talked about the support the sector is going to need from investors and how do investors view the emerging opportunities in this sector. But as the new opportunities emerge, it will be very critical to get the fundamentals right in terms of systems design that will enable structural efficiencies to manifest at scale. In part, that is the lens we are also going to be using to deal with today's topic of emerging digital healthcare scenario. To share his views on this important topic, I am very happy to welcome Dr. Nachiket Mor, visiting scientist at the Banyan Academy of Leadership in Mental Health. Dr. Moore has vast experience across sectors and among other roles has served on the central board of RBI and has been the national director of the Bill and Melinda Gates Foundation. We also have with us Professor Sahay, faculty marketing area at IIMA. To all the participants, please send in your questions in the Q&A section and not in the chat section. That way, it'll be easier for Professor Sai to pick up a few and address it to Dr. Moore. Now, I hand over the platform to Professor Sahay to take over the proceedings.
Thank you, Anurag. Good evening, everyone. Thanks for joining us on this session. I just want to build a little bit on the profile of our very eminent guest that we have today with us, Dr. Nachiket Mor. Nachiket, of course, as all of you know, is a PGP 87 from IIMA Ahmedabad. He also has a PhD from the University of Pennsylvania in economics, and he's spent a considerable part of his life as a banker. And then as a banker, he was fairly deeply involved in the area of financial inclusion. And I guess as part of that, he moved on to serving some time in the board of the Reserve Bank of India. More recently, over the past few years, he has been concentrating on healthcare issues. He served some considerable amount of time, perhaps about 3 years or more, with the Bill and Melinda Gates Foundation. And that interest continues, and he brings to bear the same rigor and intellect into examining issues related to healthcare now in his capacity as principal scientist with the Banyan Academy. Today, what we have on the agenda is to discuss some aspects of the digital health mission and India's emerging digital landscape, health landscape. And within that rubric, we've chosen to focus on a few points related to the primary healthcare system and accessibility and affordability, especially pricing some of these services to people who need it. You may be aware that if we look at the primary healthcare system for a population of about 1.25, 1.35 billion, if we assume that each unit of the primary healthcare system serves around 5,000 people odd people, then we need somewhere between 250,000 and 300,000 of these centers. Now, a key question which arises is how can digital health provide the level of service that is needed at each one of these centers? For the urban centers, perhaps the need may not be that high, but for the not so easily reached centers, that is a service that would make an enormous difference, considering that our healthcare expenditure as a percentage of GDP is considerably lower than what you might find in many other countries. Of course, some developed countries are at astronomical figures. The US is at like 17 or 18%. That's absolutely not sustainable for us. But even the question is, how can we leverage our percentages, 3%, 4%? How can we leverage that better to provide better service at that level? And at our per capita income levels, and here I'm referring to the document that you have sent me, Nachiket, the per capita expenditure on healthcare services is around 4,000 rupees in India, out of which 1,000 takes place on primary health, and around 2,500 is out of pocket. So given that even after the advent of some insurance schemes, out of pocket expenses are quite high, there is a certain level of price sensitivity as well in the customer's decision to access primary healthcare services, preventive healthcare services. And therefore, a question that arises is, what is the price elasticity? Now, we actually here at IIMA had done a couple of studies which specifically examined the impact of DPCO and NLEM 2015, 2013 and 2015. And we actually found that for 108 molecules and 348 particular formulations, we're using data between 2011 and 2018, that actually DPCO had not really impacted the sales and affordability access, if you will, for patients. Using event study analysis and regression discontinuity, we figured that as an aggregate for these molecules, there was no real increase in the sales. And if we broke it down by certain categories, for some categories, actually the sales went down. And for some categories, the sales increased marginally, but at an aggregate level, sales actually went down. So with that as the backdrop, I would like to hand over to you, Nachiket, to kind of take us through on your views on these issues. And with your permission, I will jump in at different points in time to perhaps gently direct the conversation. And we have till possibly around, it's almost 6:10, so maybe around till 6:40, where we can have the conversation, mainly driven by you. And then we will kind of open it up to the audience for their questions. So over to you, Nachiket.
Yep. Thank you very much, Arvind. I want to, first of all, thank the Institute of Management Special Interest Group for inviting me to this very interesting dialogue. The questions you are raising are absolutely important questions. And, obviously, while the questions are clear, the answers are going to need debate and discussion. And I think fora like this that connect to a much wider universe of practitioners, academics, thinkers are really the right place to go about doing it. So let me try and touch upon a few themes that you raised, and then we can explore it through dialogue. Is there something that you feel I should delve into a little bit deeper? So one issue, in some ways, technology presents us with is, what is our vision for what we see healthcare? And I always like to start with the distant future, because then we can allow visionary thinking full play without the constraints of the here and now. One alternative vision one could imagine for 2030 or 2040, maybe even, is a future in which we are all running around with our mobile phones and using one app or the other, connecting with physicians who may be in India or maybe anywhere in the world. There's no real restriction once you go on the net as to who you talk to and who you consult with. And based on those conversations, you then decide what you want to do. Take the medicine that you need. And again, automation play a big role there. You have electronic health records that are being planned as a part of the National Digital Health Mission. There are e-claims and all of the electronic objects that will allow movement of insurance money back and forth. So one can well imagine a world in which you're really only contacting somebody when you need a surgical procedure. And other than that, you're not really physically in contact with anybody. That's certainly one vision one could imagine, and technology could facilitate that. I must say that is not the way I think things ought to proceed. They may proceed in that way because you are seeing, some signs of that, particularly during COVID, at least in India, though elsewhere in the world, in the US, for example, you saw a big spike in this kind of remote consultation, but mostly those consultations were people with whom you were already consulting offline, not just some random person you found through a search engine. And then very quickly, these numbers have fallen back down to have it's quite a bit higher, the electronic consult relative to the in-person consult, but it's gone back to 70–80% of the pre-COVID levels. So it's not clear to me what the trend will be. What I do believe, though, that in the patient interest, we may have to find a way so that the momentum and the center of gravity for patient care remains with a local provider. And that technology, instead of bypassing this provider, because the previous vision I outlined is a vision in which effectively the local GP, the local pharmacy are all gone. By 2030, 2035, you see nobody. You're really, it's kind of what is happening to restaurants now in the world of Swiggy, in which you are really seeing only back-end closed-door kitchens serving you all manner of cuisine, and the front end is starting to vanish. You can imagine that such a situation the first vision could result in that. My sense, though, is that that would not be in the patient interest, because only a part, and I would submit to you perhaps even a small part of what is needed is engaging with a specialist or engaging with the right doctor. Clearly that is important. I'm not saying it's not, but a lot of it depends on what you do with that information and how you action it. You'll hear a lot of enthusiasm, part of which I share, about new biomarkers and new directions in which technology is taking us. The reality, though, is that there are already biomarkers that we are well aware of. HbA1c, your systolic blood pressure. In fact, the simplest biomarker is your weight. These are biomarkers we are well aware of, or at least weight we are well aware of. We're not acting on them, though. It's not as if you're not getting obese doctors, for example, right, who should be well informed. And in many parts of the country and the world, unmanaged hypertension, or people who know they're hypertensive, continues to be a rampant problem, leading into eventually chronic kidney disorders, brain aneurysms, all kinds of, what they call the silent killer type perspectives. Also, I hear what you said about price elasticity. My understanding is that there is more going on there than the price. Price is actually a derived function, and that's an area that I feel like it's something that needs research, and involving you, your students, and others in that would be, I think, quite useful. There is a deeper distortion of preferences, partly driven by information asymmetry, but partly driven by the fact that I tend to discount the future quite a bit. Even though I know I'm hypertensive, even though I know I have cardiovascular disease, I will not seek care for it, even if it's offered for free, or even if it's offered for a very small price. If you see, Poverty Action Lab has now a summary, which I cite in that paper, of multiple studies in which how rapidly demand drops off for primary care. And in some cases, what you find is you may even need a negative price. You may need to pay people to seek a particular type of care. For example, cervical cancer screening. Countries that do it well actually incent consumers to actually seek that screening and pay for it via a much larger insurance scheme or some other mechanism that does, primary, secondary, tertiary cross subsidization. Given all of that, I see technology playing almost the opposite role, which is instead of bypassing the front line, it enables the front line to build mass. My favorite image is that of this from the movie Matrix, in which one of the characters is taught by technology how to fly an aircraft, a helicopter that she has never flown before. Right? In technology enabling the front line, would be, I think, the direction I would want to go. Now, you might say, as you said earlier, we need 300,000 centers. Where are the frontline providers? Well, there isn't really such a gap as you might imagine. Right? We have more than a million pharmacies in the country. We have about 1 million providers, most of whom have fewer than 5 employees. So really tiny players dotted across the country. And people around the world, if you look at the experiences of the US, of a remote place like Alaska, Brazil, Ethiopia, the core of the health system has not been the MD or the MBBS physician. It has been some form of a para-professional who is trained to provide these kinds of services under strong supervision.
So if I may interrupt you there, Nachiket, it's very interesting you should say that, where the core of the healthcare system is a para kind of a system, and that technology you see as an enabler without taking away the local presence, if you will. You mentioned that the momentum and center of gravity of healthcare, in your view, would remain local. So if I put those two together, we have an interesting observation / question which is coming up, where Sushil is essentially saying that if you look at HIV monitoring in Africa at its peak, they did it using technology where perhaps some reskilling was done at the ground level, but the actual diagnosis was taking place maybe in the cities. So is that what the future is, the vision that you see as kind of playing itself out, where yes, a certain level of skills and a certain level of presence, healthcare presence is there locally, but the specialization and the higher level skills are more concentrated in clusters perhaps, and the local paramedic or equivalent has a certain base level of skills that allows the application of technology for the required diagnosis. Because you could say that there are two parts of it. One is the diagnosis and the other is the treatment. So far as the diagnosis is concerned, that would apply. The treatment might be, if it is simply medicines, that's simply a matter of access to medicines. If it is surgery, then we could have a different model.
Yeah, very much so. I clearly see technology providing wherever it can help. If I look at the Alaskan model, for example, young men and women, high school plus minus, BSc biology plus minus, with 1 or 2 years of training, in a nursing type of background. And in many US states, nurses themselves are permitted to do independent practice. So they will prescribe, they will diagnose. If there is a gap, and this is where technology can play a role to audit, to make sure there's quality control, that there is good engagement with the patient in a very structured manner. And yes, to the degree that back-end technologies are more efficient at doing some diagnosis, by all means, blood needs to be sent up, images need to be sent up, images may be processed using AI right there using some backend server. But the activity in terms of the patient will very much, my expectation, my hope will be centered around, when you said 5,000 people, I expect a small team, what the Brazilians call the family health team, to be resident in the village or in the middle of that action to do all the work that is needed and to prescribe, to deliver the medicine. Now, many enabling laws have been passed that allow much more fluid interaction between a frontline provider and a back-end individual. And even the role of the specialist. We have this image of the specialist as in, as soon as a specialist comes in, the general physician is set aside, and now I'm directly talking to the ENT doctor. The model that, University of New Mexico, for example, has pioneered this approach called ECHO, in which that's not the conversation that's happening. The conversation that's happening is between the specialist and the frontline provider. Sometimes with the patient present, sometimes, and most of the time with the patient not present. It's really more of coaching, training, because we have somehow this sense that there is, a hard barrier between a quack or a paramedic and a highly trained provider. When in fact, it's a continuum of training and exposure and certification that actually changes the framework. If I look at, for example, Thailand, they built an entire health system, starting with the equivalent of what we call our ASHA worker. Their ASHA worker of 1995 is today's oncology nurse, because they didn't take the view that somehow one person is crafted, out of different material and the other person is crafted out of different material. It's the same individual. You train, you expose, you certify, you re-examine, and they gradually, over a 10-15 year period, acquire the capabilities that are needed.
So when you say that, specifically when you said that the ASHA worker of 1995 evolves into an oncology nurse in 2020, if I make a comparison, for example, you also gave the example of New Mexico. If I look at NHS as an example, right, the National Health Service of England, and how their system works. So it is built around these GP practices. The GP practices have a certain budget which is allocated from the NHS level, which is based on the number of patients that they are serving. And for certain medical conditions, the GP will refer them to the specialist. Now that specialist is sitting as part of a larger group which is serving a number of GPs. And so the number of patients that they're serving is larger. And when the specialist serves, he can very frequently be serving at a distance, right? The person is not actually going to that specialist hospital, but being served at a distance. So clearly what you are saying is that there is a combination of a systemic view to setting up the healthcare provision service of the future, and how digital will kind of come into play when these two come together. There has to be a basic provider that is local. Even in the NHS, the general practitioner is the local, and there are other dimensions, the development of relationships between this GP's practice and the patient, right? The patient knows this doctor and the set of people.
And it cascades up, just like we say GP to patient, there is the whole relationship between specialist and GP. There is a relationship between super specialist and specialist. So for example, during the COVID-19, in some other project, I was involved with a company called Cloud Physician. So Cloud Physician works only with hospitals to help them run tele-ICU services. Again, the vision is the same. The hospital is located in a small town, in a district headquarters. Patient is not being flown to Chennai or to Bangalore, but the back-end technology is reaching into that hospital and creating a modern ICU with the help of local doctors, local specialists, but they are not pulmonologists necessarily. They are not critical care specialists necessarily, right? They may be MBBS, they may have done general surgery, but they don't really have all the background that is needed. So I very much see this kind of cascade, starting with a frontline nurse. Let's imagine a nurse practitioner type model, maybe auxiliary nurse, midwife, that kind of structure, all the way going to much higher levels of skills but staying as close to the patient as possible, rather than this other world in which the patient is being transported digitally across virtual spaces to be consulted with in Liverpool.
But why is that not a sustainable model in your view? Clearly, your stance is that remote provision of service from a physically very distant provider of the service is not a sustainable model in a sense, is what you're suggesting. So can I kind of push you and ask you why that should be the case?
Because see, a number of challenges, as I mentioned to you earlier. Why are we not getting hypertension treatment done? It's not that we don't know the biomarker. It's not that we have not received good advice. Or why are we not working on our weight? It needs an engagement on a constant basis. So if I look at the GP model, only one portion of it is what you described. The key aspect of it is that now my health is the GP's responsibility. And of course, you could say I could do that through digital messaging, I could do that through SMSs, etc. But there is a need to spend time with the patient, build trust with the patient, be aware of a fixed cohort that you're working with, and you are really engaging the patient in a high quality manner. Now, you might say the world of the future, you could imagine a world in which people are able to engage in that way with Siri or Alexa and build that kind of a relationship with a remote agent. I feel until that happens, the front line will have a lot more, and medicine is not quite, the science is still not quite there. If I look at RCT results, if I look at numbers, right, it's not as if we understand biology in a full manner. Again, it needs a lot more local engagement to understand what is the manner in which I work with this individual patient. There are a whole lot of cultural dimensions. For example, women will not feed colostrum, the green substance that comes out immediately from the breast, to the baby. Now, one could poo-poo it and one could say, I sent you an SMS message, why didn't you go ahead and do it? But actually that may not work, because you have to understand what is the cultural perspective from which that woman is coming. And really you need a local person to be working with her to do it. And, and in my view, we have no real shortage necessarily of 12th standard pass young people or BSc biology young people to enable something like that.
So just picking up on that last point that you made, I completely agree with you that there is an issue of culture over there, and colostrum being fed to the newborn baby is very, very important to build up immunity. And one has to change the behavior of the people. And that ties into behavioral science and what are some nudges that one can use to try and change the behavior. Now, again, one can take two particular points of view on that. And one point of view clearly is that a local person who is known to that individual, in this case, the new mother, is much more likely to achieve the behavior change. The other point of view is that perhaps that behavior change may be applicable, that type of requirement of a person to effect behavior change may be applicable in some instances where the cultural mores are very much ingrained into the person, and the one that you mentioned is clearly one of them. But there may be others where in diabetes or asthma, many chronic conditions where actually what is required is a kind of a nudge to change a habit. Now, habits are, from a behavioral science perspective, there is what we call as a stimuli, action, and reward loop that's going on inside the head of the person. And so long as I can change the reward in some way and break that stimuli, action, reward loop and hook the person onto another loop, which is closer to me. Now, that one could argue, a person taking their diabetes medicine on time, for example, that one could argue is much quite easily accomplishable through digital means also.
No, so I'm not presenting this as an either or idea. Right? I'm not saying that either you go this way or that way. I'm fully imagining a digitally enabled world. There are two visions though. One vision is there are only specialists in this world.
Yeah.
Right? Of whom we have a very short supply and they are pretty expensive resource.
Yeah.
Or we have a world in which those specialists are very much there.
Yeah.
right? And they're not, because you could have a third vision in which there are no specialists, there's only AI, right? You're not talking to any human being at all until you need surgery, right? I feel we are in medicine quite a distance away from that, right? But if you imagine a specialist,
yes,
all I'm saying is that a local agent,
yeah,
like an MBBS doctor that is
yes,
practicing as a GP,
yes, yes,
the UK GP is the equivalent of that,
yeah,
is a useful and an important bridge, can handle 80-90% of the issues directly on their own with technology assisting them.
yeah, yeah.
Wherever necessary. For example, there is a company called Visa, right, that offers you for cognitive behavior therapy a chatbot.
Uh-huh.
There's another organization called the Center for Mental Health Law and Policy that offers you a master trainer to train your frontline worker to offer mental health services. Right now, it's possible to switch between these two worlds in a smooth way. Sometimes a chatbot is more useful.
Yeah.
Sometimes a frontline worker is more useful.
Yeah. Yeah.
All I'm saying is I don't see a world in which the frontline individual is missing entirely.
Okay,
that's the point I make.
I hear what you're saying. I hear what you're saying from specifically from an Indian context, and there is a very interesting observation that has come up from, I don't know what that means, Bolus W1, whoever you are. Let me actually read that, what his question to you, Nachiket. Right now, a healthcare practitioner in India spends on average less than 5 minutes per patient to diagnose and prescribe. Isn't it better that there is more thought involved in the background before prescribing to the patient? So this kind of ties quite well to what you are saying. There will be some situations where you will need one kind, and so it's the design of the system.
You build a relationship with the patient. You need to understand what is going on. The initial consult may take up to 2 hours, and you have to have a sense of, is this patient in a hurry just now? There's some very nice work out of the 60s from UK GPs when they were early starting out the practice of understanding proactive customer-centered care, in which they concluded that separate preventive care action, patients don't participate. You can go ahead and do advertising and do camps, that doesn't work. When a patient has shown up with a need for something else, that's the time you have to engage the patient in a fuller conversation. And this person is quite right. A transaction-based approach, which again has become somewhat of the hallmark of the current telemedicine type approaches, where you log in, you have a 15-minute time frame, and the person is only simply interested in, okay, quick, you tell me what's wrong with you, I'll give you an answer, and you go, right? An environment in which I get to know you, I even, Cubans emphasize this quite a lot. I visit your family because I just don't want to know you. I want to know what is the circumstance in which you are living. Right? Why are you consistently anemic? Why do you seem always overworked? Right? What is going on? I think these will have an important role to play for a time to come. Even for upper income households, we have this belief that it's actually the low income people that are not getting good health care. I would submit to you, most of us in this audience are not getting good health care. Right? How many of us have done a colonoscopy? How many of us have been told that a colonoscopy done every 4 or 5 years is an essential part of a colon cancer, one of the fastest rising cancers in India, a mechanism? We have not, right? So in some ways, this kind of engagement combined with all the behavioral nudges, etc., I think then becomes a very powerful wellness, illness, referral management tool.
It's fantastic and interesting that you are suggesting that because India seems to be in a place where we are following more of the transactional model at this point in time. And as I quite agree with you when you said that whether it is the lower income guy or even the higher income guy, it's very much the norm. So if for the moment one assumes that what you're pointing out is the way to go, and this example that you cited of Cuba is pretty good because Cubans have pretty good health outcomes, and that is the system that is based on more holistic system. Then the question essentially becomes what is the path? And here this whole business of path dependence, right? We are at point A, we would like to be at point B. How does one get to point B? And as Baldeep Punia is saying over here, that we cannot forget the role of human connection in healing, which is essentially what you are also suggesting to us. And how can you afford the digital enabled infrastructure that has a healthcare worker without a holistic training? Exactly what you're saying. So what is the path forward therefore?
There are two pathways. One is what I would call the first best pathway, which is the ideal pathway, which many countries have taken, which is the government steps up with the money, not necessarily with the care.
That's not going to happen here.
Pardon me?
In this country, the government stepping up with the money for healthcare.
I'm saying may not happen today, may not happen everywhere, may happen in Meghalaya, may happen in Goa, may happen in Himachal. I wouldn't rule that out entirely. But I'm just saying that's an ideal mechanism, because in that mechanism, what then happens is that you can recreate versions of Kaiser Permanente or the Brazilian or the Costa Rican family health team model or the Thai approach. A lot of these models have assumed as a prerequisite government money. And it's, you know, the interesting thing is, while some countries have taken health as a important, you know, kind of good right 50, 60 years ago, even in the last 20 years, there are many countries that have upped their allocation to healthcare dramatically. And it's not just the rich countries. I mean, Iran, for example, has doubled its contribution to health as a proportion of its GDP. Despite all of the other challenges that we hear about Iran, on this front, they have done something quite remarkable, right? And of course, China is a well-known story. You know, the China of 2000 and the China of 2020, the amount of money government has put in. So I wouldn't rule that out. But you're right. I worry that, in fact, the direction is the opposite that we are seeing. If you see the richer states, states like Maharashtra, for example, or Kerala, for example, or even in the South, the government's contribution as a share of its GDP is actually falling as incomes are rising, right? So in some ways, in absolute term, they are maintaining the numbers, but in relative to their incomes, the numbers are actually falling. So then the question comes up, okay, we are then left with an environment which is an out-of-pocket environment, where people have to spend their own money to do their own care. And this is really where, you know, what I was talking to you about, you know, fresh thinking is needed, because one of the challenges that we have faced, the insight that out of pocket is the dominant area is not a new insight. The insight that customers need to be given better value for primary care is not a new insight. Unfortunately, if I look at the actual Indian experience of startups that have entered the primary care space, right, it's been consistently poor. You know, there has virtually been nobody that has gone, I can't name a single chain today, primary care chain, that has gone to, you know, 10,000 points in a country which needs 3 lakh points. You know, why don't you have a chain that has 3 lakh points? I think there are two sets of issues there that I feel needs more research. One is what I pointed out in that paper of mine, which is, I think customers are not responding well, you know, to this kind of an approach. They seem to be signaling that they prefer a transaction approach. And you could argue that there is a trust issue, etc. But there are high quality NGO players that have been operating in that area, in densely populated areas like Dharavi for a decade, 15 years, right? And yet they get only half the traffic that they need to break even at the clinic level. Forget about at the larger system level, right? What is going on? What is the customer seeking, right? In tuberculosis, for example, you know, there is very nice work done by the Indian School of Business faculty in Mehsana. What they find is, on average, for a single episode, customers are consulting as many as 3 to 6 providers, right? And in our own lived experiences, you know that, you know, this was not a happy experience. Let me talk to that guy. Let me talk to that guy. Right? And then, of course, the other issue is what, you know, somebody mentioned on the chat as well. You know, on the supply side, has there really been a complete proposition that somebody has put out? You know, so one could argue, you know, as Rama Bijapurkar, you know, so one of the people that I studied under, you know, she consistently makes the point that as a marketing person, first you have to establish that the sum total of the value you're adding minus the price you're charging for it is a positive number. If that's not a positive number, then any effort at advertising and sales eventually is not going to peter out. So I think that's an important issue. But I do believe that if we, with all the creativity that our IIM business schools, young people have, we can crack this. We can get a sense of how do we get consumers to build relationships of the type that are necessary. I think even in an out-of-pocket environment, we can make a lot of progress. It won't be as good as what I described as the ideal, but today customers are, for example, I don't know if I mentioned to you when we spoke last time, in the south, a state like Kerala, a state like Telangana, where money doesn't seem to be as much of a problem, C-section rates have gone through the roof. Karimnagar is showing C-section rates, average C-section rates at 60-65%, and not just from the private sector, also from government providers.
Yeah.
Which means the market mechanism is misdirecting the money away from what it should, which is primary care, towards services that are not very useful.
I couldn't agree with you more, but there, let me take you back to a point that you were making about the study where people are going to 3 to 6 providers to take different opinions, and compare it to the UK system where perhaps you go to the GP and you trust the GP, and therefore if he says what this is to be done, he refers you to someone, you're quite happy to go along with that. Now, these are two very, very different systems, and I keep going back to how to proceed to a way where people are comfortable and do not do this kind of shopping around for something. That requires the building up of a certain level of trust, and that takes time, because we are wired.
People with 10 years.
So far as our heads are concerned, we are naturally wired to compare. We will want to compare only after we have built up a certain level of trust. So therefore, to kind of narrowly focus more on the path going forward, if I can invite your comments on what are some 3 things that you would advise everyone, including entrepreneurs who want to offer AI-based agents frontlined by local basic trained personnel. They will also need this trust. How does one go about building this trust? What are 3 things that can be done by, let's say, the government to build this trust? Or what are 3 things that can be done by a local small town hospital to build this trust?
I mean, again, you're the marketing professor, I'm not, but my experience or my belief is that trust comes with experience. And if your experience with your doctor is that the doctor is serving you well, spending time with you, wants to get to know you, understands what your issues are, is a good counselor, is a good friend, and you genuinely believe this person is acting in your interests, trust builds rapidly. Right? Unfortunately, I'm not seeing the supply side gain that insight. Right? The supply side keeps insisting on transactional approaches to go about doing it, recommend some random diagnostic test, give some medicine out here and there, and medicine, while AI, ML, etc., can play a lot of roles, there are fixed protocols that we already know about. Right? How much of that are we making available to our patients? So to me, clearly, that building of trust is a journey, and you're quite right, it may take time, but people have been there for 10 years, 15 years, and NGOs, highly ethical, high quality people, even they are not getting success. In fact, there are very few models, even at the individual clinic level where you're getting this behavior. So maybe that's one kind of approach that one can imagine. The second, I feel what has happened is, and I worry that technology may further exacerbate that trend, is that we are shy of building mass in front of the patient. A lot of our thinking is referral. Let's talk to the specialist. Let's do this. Let's do that. Whereas if you look at the US Preventive Services Task Force recommendations, right, somewhere near 120 to 130 procedures can be dealt with in primary care settings. For example, all of the cardiovascular endocrine issues that you mentioned, I can do a great deal right at the first point of contact with no referrals. Right? Only when a patient proves to be refractory, I'm not able to get results using standard accepted practice. Right? And now the standard accepted practice becomes important, because if I'm going to do all of this and offer my patient cancer care and diabetes care and something else, I'm going to need tech, but I'm going to need to then subsume my ego a little bit, deal with my God complex a little bit, and really work with the technology. use electronic health records. I find, there is a standard protocol called SOAP, Subjective Objective Assessment Plan, right, which is the core of primary care practice. I'm not meaning primary care providers that follow that process. Okay. They rely instead on, when the patient walked in the manner in which he walked, I figured out the diagnosis. Yes, that may have been true some years ago when statistics was not such a key issue, when you didn't have all the tools that you could give. I feel some of these, but I think some of it will need new work, Dr. Sahay. It will need a deeper understanding of the behavioral type that you specialize in.
Thank you. Thank you.
What is the patient looking for?
So, Dr. Mor, I think let me now come. I have been trying to weave in some of the questions into our conversation, but there are some others which are slightly kind of different. So let me go to the last one first, which I can see on my screen. Perhaps you can see it on yours as well. At the apex of the healthcare delivery chain, which is surgery, perhaps, it seems to be immune to democratization and decentralization. Your thoughts and views on that?
I mean, there is no ambiguity in my mind that tertiary care, particularly, but to a large degree, secondary care has to be insurance financed. This idea that we are going to have low-cost surgeries. In fact, I feel attempts to bring costs of hospitalization down are misdirected. Because what you want is actually fewer people showing up rather than more people showing up for cheaper surgeries. And we have to build an insurance cover there, right? This idea that we'll show up with 5 lakh rupees and 25 lakh rupees in our pockets to pay for this surgery or that surgery is just inconsistent with the manner in which finance should be designed. Primary care, though, I would submit to you, can be paid for out of pocket. There is low uncertainty with it. Insurance is not a good tool because it will charge you 20%. So you gave them 1,000 rupees, they spent 800 rupees on your behalf, kept 200 rupees. Right? The role for insurance is to take care of your behavioral issues. In fact, that's why the tertiary care insurance is referred to as pooling, primary care insurance referred to as prepayment. Because it's really meant to discipline you as a provider, as a consumer, and to discipline the provider so that they are acting in your interests and not, excessive care. But I feel at the surgical level, once we are clear what we are doing in primary care, we have to we can't do 70% C-sections, and I fear that the cheaper you make it, the more what has happened to amoxicillin is happening to C-sections.
Yeah. Quite true, quite true. In fact, what you're saying kind of jives very well with what Shashi Bhushan is saying. Essentially, he's kind of questioning whether you can replace specialists with AI, where each patient thinks that his illness is unique. So that's the behavioral science part of it. Let me go to the question of Anushri Jamdar. A major proportion of our population resides in villages. And what is your sense of the acceptance of this digital distance kind of a technology by patients? Are they happy with it at this point in time? How is the accessibility and adoption at this point in time?
No, sadly, ma'am, the problem is they have neither availability. They have neither this nor that. However, if I look at the experience people have today of electronic money, of UPI, the adoption has been far quicker than you might imagine. So it's not as if people won't adopt technology. But if you see the core of my argument, I don't believe that the right idea is to rely on individuals transacting using their mobile phones directly with specialists. I believe the world at their level will very much be a local doctor. I'm thinking more a local nurse will show up at your doorstep. She's highly trained. She accesses technology. But when she's talking to you like a doctor would have been talking to you 50 years ago. So in some ways, the tech is hidden. It's like when you use a Blu-ray player, right? These days nobody uses Blu-ray players. Maybe, if you switch on Netflix, you don't know all the technology that went in to do streaming, this, that, and the other. As far as you're concerned, you put on the TV the same way you would have put on the TV in 1985.
Very interesting. Nishant has a very interesting question, which is on how do you get to pay for all of this? Is there a reason for pharma benefits manager like entity to exist in India and control the healthcare decision making more effectively? Well, one could question whether the US model of pharma PBMs is effective, but that's the question.
I mean, we go back to that issue, Dr. Sahay, which is where is the pooling going to happen? Ideally, government should be using tax as the mechanism to pool, but as we've discussed earlier, that may be a little bit, like waiting for Godot. Other possibilities, you expand the health insurance market. India could be different, but the global experience has been that health insurance has been a great tool for top-ups and may in fact be a very good tool for tertiary care insurance. So you could imagine a universal tertiary care product, not quite like the one we have, which I would call a deductible insurance, where you cover up to 2 lakh, cover up to 5 lakhs. Insurance is the opposite. You pay 50,000 rupees, then unlimited amount is paid for by the insurance company. Right? What we have got in India, again, for a variety of reasons, is the opposite. It's just, it pays you a deductible. If tomorrow you need a pancreatic cancer surgery, that's 25 lakh rupees, insurance is not going to help you. Right? But can we really design those products? I think those, I can imagine a payer type structure, controlling tertiary care hospitals. I can even imagine a role for government. Government has entered the secondary insurance market. I think that's a bad entry point for the government and for poor people, which vaguely defined. Right?
Well, we could argue that that's a political messaging more than anything
else. But I would say,
I
think even politically, I think a much more powerful message would have been universal tertiary care. Everybody. If you, have cancer, government will take care of it. You don't have to worry about it. It's not that expensive. See, that's the beauty of insurance, right? I think it would have won them a lot more support.
Brownie points,
and a lot more. And I think it is more consistent with a high quality health system. And there's great papers by Filmer, Hammer, and Pitchett that talk about this kind of a structure. The rest of the market will have to remain somewhat out of pocket, at least for a while, is my sense. This idea of
that would address the disparities between states to some extent if the center were to take that initiative, because as you pointed out, some states like Meghalaya, etc., are increasing, whereas others are Maharashtra are decreasing. So if that initiative were to be taken, then I think the point that Ullas is raising would probably get addressed. Let me go to the next question, which is that we have one which we had missed earlier, which is from Siddharth. There is a view of that digital diagnostics using low-cost, readily available mobile devices linked to a smartwatch with AI-based agent and frontline by local basic trained personnel. So I guess we have already looked at this. So unless there's something more, Siddharth, than this question, I'm going to skip this one.
I must say one thing I am nervous about, right?
Anji.
Which is excessive care, excessive interest. We've seen this happen in breast cancer. The old idea was self-exam, then became clinical exam, excessive treatment, excessive procedures. Now, for example, it is clear that for men, the prostate-specific antigen to detect early prostate cancer is a bad idea. You will get upset, you'll get anxious, you will intervene early. The intervention will hurt you more than the disease. Actually, prostate cancer is a very slow-moving cancer. Often people outlive it, right? So this idea that I'm doing continuous monitoring of my blood pressure, right? It worries me. Because I have not seen too much evidence of this kind of high-frequency monitoring producing anything but bad outcomes.
Interesting, very interesting. Which kind of connects also to another question, which is right now we are a young country, but we do have a very large population in absolute numbers of old people. And close to 1/3 of the geriatric population, I'm quoting from what Gopi Krishna has written over here, have been found to not benefit from digital or telehealth monitoring solutions, partly due to inexperience and partly also because of what you're saying, too frequent monitoring does not really help. But to the extent that it does help, any thoughts on how one can provide a more equitable access to digital monitoring or telehealth monitoring solutions for older people? Given that our social structures are changing, many of the older people are now living by themselves rather than in a family structure, joint family structure.
See, the good thing in India is that to build out a cadre of dedicated frontline personnel is not expensive. While people have been a little bit burnt by experiences in other sectors, If I look at, for example, my favorite company is the Urban Company. If you invite one of those people in, even if you discount all the advertising that they're doing, I have direct experience of them living in Bangalore. It's a really high quality experience. They are able to deliver to you at home an experience of cleaning your toilet that is superior to what I have seen, provided by healthcare providers. Right? So it's not difficult for us, I would imagine, in good hands to deliver a really high quality, personalized, extremely low cost. The number of young people without jobs today, after finishing high school, after finishing basic BSc biology kind of graduation, is very high in the country. I think that building that bridge, because I think what we are trying to do is to assume that this individual is not there. Immediately go to the old individual and say, oh, why don't you strap this on and strap something else on? I'm not even convinced that's a useful thing to do. And in a kind of roundabout way, I'm happy that that's not working. Because I worry that we will then end up unleashing a demon of all kinds of random procedures, and expense after expense after expense, based on what? Not entirely clear.
And actually, this kind of ties very well into the ideas that we had been sharing when we talked the other day on a healthcare systems design. Clearly, one of the things which is emerging from this conversation is that whether it is trying to put technology at the edge of the system where people like nurses or paramedics are trained up to a certain level to interact with the rural population, or some gadgets for the geriatric population. In each one of these cases, it is important, or whether it is for at the local town hospital rather than the specialist hospital. In each one of these cases, it is important to figure out where that particular service lies in the overall system, the healthcare system that is in operation. And the primary healthcare system hopefully is set up to take on board a majority of the requirements. You mentioned up to 180 procedures can take place within the primary healthcare system. And the issue of funding of this, again, if I gathered correctly, your view is that it is possible for us to go even further than where we are, even within what we are spending just now. But clearly, that does need to go up a little bit more than what it is just now.
I would say the opposite. We are spending too much money on random medicines, on buying antibiotics that we don't need. Cough syrup is the highest selling item in the country today. It certainly is helpful to some degree for children if they can't sleep. But by and large, it is just a sugar-filled drink. So it's not obvious to me, that we are really getting the kind of value we need from our current expenditures. And to some degree, I think if we start to talk about a universal tertiary care type insurance product, some of those insurance products could, for very high risk patients, also come through with some compensation to doctors, not because patient needs to pay, but because an insured patient now needs to really worry about their high risk conditions. And then don't forget the corporate market. See, the corporate market is reasonably large. Unfortunately, you're not finding corporates today that are, that may have 300, 400 or 5,000 employees, and some of them have decided to go for self-insurance, but as yet have not taken charge of the well-being of their employees, even though it would cost them virtually nothing to do that.
Very interesting.
Interesting payers could emerge once we start to think in this way about how we deliver health to our populations.
Yeah. So I think we are kind of almost out of time. So let me draw our conversation to a close, Nachiket. Thank you very much, Dr. Mor, for being with us today. That was a very, very interesting conversation so far as I was concerned. Personally, I hope to be able to continue this conversation with you. And a lot of insights over there from the fact that the whole insurance model seems to be upside down, the fact that there is an issue of systems design rather than focusing on individual parts of the overall system. The fact that the role of the local provider is probably going to continue, and we need to focus on marrying technology to that role of the local provider And to some extent, you cited the GP model as something that we can learn from and emulate, at least partially, if not fully. And the issue that we seem to have moved in the opposite direction to where we should be moving. And the C-section part was clearly one of those. So thank you very much again for your time, Nachiket. And I'm sure the audience has had some value out of this. And thank you, Anurag. Thank you, Vidhi. Thank you, Ulas, for giving us this opportunity to have this conversation for this audience. Thank you very much.
Thank you, Dr. Sahay. It was a wonderful discussion. I really enjoyed it. I really enjoyed many of the questions and comments from the audience as well. And I'm certainly hoping to persuade you, your students, and other academics to really look at some of these questions that I think have been under-researched in the Indian system.
We should definitely continue this.
To do something.
We should definitely continue this conversation, and I will be I'm hoping to pull in Ullas and Sudarshan as well in this conversation. So
no, that would, in fact, we didn't get into the role of pharmacies. Pharmacies, I think, can play an important role. Many countries have used pharmacies as the new GP, as it were, and to bring some of that into the pharmacy network. We've all heard about the CVS Minute Clinic. Versions of that are very easily possible here in the country. Thank you. Thank you very much for inviting me.
Thank you very much.
Thank you, Anurag. Can we sign off now?
Yes, we can. Thank you.
Thank you. Bye-bye.
Thanks, Anurag. See you.